Hi everyone, I'm Andrew Guyman. I'm a fourth year medical student at the University of South Dakota, Sanford School of Medicine. We're continuing our Anesthesiology 101 lecture series. Today we're on day 8 discussing vasopressors. So the learning objectives that we'll cover include hemodynamic equations, common vasopressors and their effects on the cardiovascular system, blood pressure cuff positioning, and how different positions can affect your reading, the importance of diastolic pressure and a few different aspects, stroke volume variation and what that means, and how daily antihypertensive medications can affect your treatment of hypotension. So, when you're trying to determine a patient's cardiovascular status in the OR, one thing that you'll probably look at is a patient's blood pressure. Blood pressure can mean a couple different things. So there's systolic, diastolic, and mean arterial pressure. Blood pressure cuff, that an automated blood pressure cuff measures a patient's mean arterial pressure. Their mean arterial pressure equals their systemic vascular resistance times their cardiac output. So this makes sense. Systemic vascular resistance, I think of as how tightly the arteries and arterioles are clamping down on the blood that's passing through it. So if they're very tight, that would increase your mean arterial pressure. And cardiac output, how much blood is flowing through the system. If you have a ton of blood flowing through, and all your vessels, your arteries are pumped full of blood, then that would also increase your mean arterial pressure. So this equation is a little bit intuitive. Then we'll just break cardiac output down a little bit. So cardiac output, that's the total amount of blood in liters that flows through your vascular system each minute. And that's going to be equivalent to your stroke volume times heart rate. This also makes sense. Stroke volume is how much blood is being ejected from the ventricle with each heartbeat. And then if you take your heart rate, which is beats per minute, and multiply those together, then you'll be left with liters per minute, which is the units for cardiac output. So you can see from this equation that if you were concerned about maybe a low mean arterial pressure, there's a few different things that you could look at. One, your systemic vascular resistance. So propofol reduces systemic vascular resistance, or sepsis is another good example where it causes your arteries to kind of expand or become leaky. So they're not clamping down as hard on the blood that's flowing through them. And that would in turn reduce your mean arterial pressure. Or if you have a reduction in cardiac output, that would also reduce your mean arterial pressure because these are directly related to each other. And then you have to ask yourself, okay, why do you have a reduction in cardiac output? Do they have a low heart rate? So are they bradycardic? And they're just not beating enough times per minute to pump enough blood through their vascular system to maintain an appropriate mean arterial pressure? Or do they have a reduced stroke volume? Maybe they're tachycardic, so their heart rate went up, but it's not allowing enough time in diastole for their heart to fill. So they're having like even greater decrease in stroke volume, and then that's decreasing their cardiac output, which would then decrease their mean arterial pressure. So if you see a low blood pressure, there could be multiple different causes, and this just provides a schema for thinking about it. There's a couple different common vasopressors that we'll talk about and their effects. So ephedrine has a primary effect on activating alpha 1 receptors. So it's an alpha 1 agonist. Alpha 1 receptors are found throughout the peripheral vascular system, and activation of them causes vasoconstriction. Vasoconstriction is then going to increase SVR, systemic vascular resistance, and then that would in turn increase your mean arterial pressure like we discussed on the previous slide. Ephedrine also has a secondary effect of activating beta 1 receptors, which is going to increase heart rate and increase heart contractility. So if you're increasing heart rate, as long as you're not becoming excessively tachycardic, that can increase your cardiac output. If you're increasing heart contractility, you can therefore increase your stroke volume because your heart is squeezing harder with each beat, ejecting more blood. Both of those would cause an increase in cardiac output, which would in turn increase your mean arterial pressure. Phenylephrine is a pure alpha 1 agonist, which is going to cause an increase in vasoconstriction, which then will increase your systemic vascular resistance and mean arterial pressure. Vasopressin is a vasopressin receptor agonist. These receptors are found in the peripheral vascular system, like alpha 1 receptors. They also cause vasoconstriction, which will increase your SVR as well. And then if you administer fluids, we talked about this in one of our previous lectures, but that's going to increase your intravascular volume, which is going to increase your stroke volume, as long as you're staying in like the optimal range of the Frank-Sterling curve, and then that will increase cardiac output, which can also increase your mean arterial pressure. Blood pressure can be affected by the position of the blood pressure cuff. So Nature released a review comparing blood pressures that were taken on the arm to blood pressures that were taken on the lower leg. They found that ankle systolic pressures were about 17, which is definitely significant, millimeters of mercury higher as compared to arm systolic pressures. Diastolic pressures didn't change depending on the position. And then because of this, your mean arterial pressure, which is made up of 1/3 systolic, 2/3 diastolic, were approximately 5 millimeters of mercury greater. So a similar idea to this is positioning. So if you have a patient in beach chair position, so they're sitting upright, the pressure is going to vary depending on where you're measuring it. So if you're concerned about the mean arterial pressure in the brain, but you have the cuff around either the arm or ankle, then you have to consider what the reading on the screen, how the reading on the screen compares to, so the reading at the arm or the ankle compares to the pressure that the brain is receiving. Now, this idea is debated because of autoregulation, but classically, there's a mnemonic that says pH equals 7.410. So for every 10 centimeters that you go up in height, you have a change of 7.4 millimeters of mercury. So to give an example, if you have the cuff around a patient's arm, so here's our patient, You have the cuff around his arm here, and then we'll say that this distance is 20 centimeters. Then you would have a change of like 2 times 10 centimeters. So your pressure difference would be 2 times 7.4 equals 14.8 millimeters of mercury less. So, for example, if the reading that you're getting on your cuff says 65, then the actual blood pressure that you would see up here, 20 centimeters different, would be 65 minus, we'll just call it 15 equals 50. So the reason that this is important is there's been like case reports where patients have been in beach chair position and they maybe experience mild hypotension as measured on their arm or even worse on their leg. And then when they tried to wake them up from anesthesia, they were actually brain dead or had significant neurological injury because they were extremely hypotensive in their brain because that's so much higher. Diastolic pressure is important for a couple different reasons. So it's extremely important in coronary artery disease. So when the heart is beating, when it contracts down, it's becoming like very tense and squeezing down on the arteries that are perfusing the heart. It contracts down in systole. So in systole, because it's contracting on those arteries, it's not actually receiving any blood flow. You have to wait until it expands in diastole and relaxes, and then blood can perfuse the heart. So when it's expanding in diastole, that's when it receives its blood flow and oxygen. And if you have too low of a diastolic blood pressure in coronary artery disease, where you already have your arteries that are filled with plaque and they're decreasing the flow that's going through there, then a low diastolic blood pressure could lead to very poor perfusion of the heart or ischemia, and could predispose you for like a myocardial infarction. So the point is, it's important during coronary artery disease that you maintain a high enough diastolic pressure so the heart is still perfused. Um, Diastolic pressure is the most important for MAP compared to systolic pressure because it composes 2/3 of your mean arterial pressure, where systolic pressure only composes 1/3. And then it can be a little bit more of a specific indicator for fluid balance. So low diastolic pressure could mean that you're hypovolemic. A higher diastolic pressure could mean that you're hypervolemic. So stroke volume variation is a numeric indicator that can help you determine the volume status of a patient. So stroke volume variation uses an arterial line waveform to assess volume responsiveness during positive pressure ventilation. Um, the idea is if you have a waveform of an arterial line and it looks something like this, and a patient is also being, so we'll have this patient over here, is receiving positive pressure ventilation. So they have a tube in, and this is like inflating their chest cavity. So we'll call this their chest cavity, and their tube's going in there, and it's inflating that. When they're receiving a breath, then you should be able to see on the arterial line waveform that there would be a decrease in stroke volume that is received systemically because the pressure that they're receiving from their endotracheal tube would be compressing the heart and then reducing the amount of blood that it can eject. So you should be able to watch that, and you'd see slight variations in this waveform, in your arterial line waveform, where maybe it's a little bit higher, and then a little bit lower, and this would correlate with the breaths that they are taking during positive pressure ventilation. Now, stroke volume variation, variation is the key word, is depending on how great variation that you get in your stroke volume, and you're measuring that off of your arterial line waveform, that correlates to the volume status of a patient. So you can imagine that if a patient has a low volume status, so think of like a very low amount of blood that's flowing through the circulatory system into the heart, then when they receive that positive pressure ventilatory breath that's coming in through the tube, then that's going to be able to compress the heart more because the heart has less blood that it's receiving because they're low volume. And then you would see more variation on your arterial line as you're watching this pass through. Conversely, if a patient has an adequate amount of blood in their circulatory system and then they receive another breath that's coming in, well, their heart is kind of like plump or full of blood, so it's going to compress their heart less, and then you would see less stroke volume variation measured from their arterial line. So ultimately, like the criteria that you would use is if you see a stroke volume variation of greater than 15%, then that's your indicator that the patient is probably volume responsive. So if they have a large degree of stroke volume variation, then you could give them fluids or colloid, some sort of intravascular volume, and then that would help improve their hypotension or perfusion, whatever you're trying to treat. The last topic that we're going to discuss here is daily antihypertensive. So, a pretty common scenario that you could see with patients coming in for their pre-op exam is a patient who reports that they took their lisinopril on the morning of surgery. Really, the biggest thing that this would cause, so if they took lisinopril or maybe losartan, you're going to inhibit your renin-angiotensin-aldosterone system. So you're inhibiting that, which is a system that maintains your blood pressure. So a patient that doesn't have a functioning renin-angiotensin-aldosterone system may have refractory hypotension during surgery. So that would be your big concern, is refractory hypotension. I hope that this lecture helps answer any questions that you have. Let me know, or any of your attendees know, if you have any questions. We'd be happy to help. Thank you.